sites, okay? Disease sites. A disease site is an area of tissue destruction. It may involve only one surface of the tooth or several surfaces. Active disease site, such as gingivitis. Each tooth has potentially 6 sites. A site is active if there is bleeding on probing. So, disease sites in gingivitis, there's 6 sites, right? Now, active disease in periodontitis. A disease site that shows continued apical migration of bone over time. It can have bleeding or inflammation. For example, 3 months ago, the deepest reading on the distal of the mandibular right first molar was 5. Today it's 6. So, now this disease site is considered the tooth. So, for example, a periodontal disease site is considered a tooth that has disease. A gingivitis site is a surface on the tooth that has disease. Inactive disease site, a site that is stable or healthy, no bleeding, no inflammation, with the attachment level of the JE remaining at the same level for a period of time. So, for example, the deepest reading on the distal surface of the mandibular right first molar has remained at 5 millimeters for a year. Majority of periodontal pockets in most adult patients are inactive. A pocket is an indicator of past destruction of perio. Classification of periodontal diseases and conditions. Okay, so it used to be called early onset perio and aggressive perio. Now it's being called graded. The perio disease is being graded, okay? So that's the only difference. Instead of going from early onset to aggressive perio, it's now grade A, B, and C. So, gingival diseases. These are what we have and talked about in class. It's on the cheat sheet. But you have gingival diseases, you have biofilm-induced gingival diseases, and non-biofilm. So biofilm induced gingival diseases can be systemic, drug-related. Let me start that again. Biofilm-induced gingival diseases can be caused due to strictly biofilm alone, systemic or local risk factors, and drug-influenced gingival enlargement. That's how you accumulate biofilm and cause disease. And then you can have non-biofilm induced, such as, things that aren't from biofilm. Okay, gingival disease subdivisions. Dental biofilm-induced gingival diseases and non-biofilm-induced diseases. So this is going to be more specific of what I was trying to explain. So biofilm-induced gingivitis. This is the most common form of gingivitis. It's where you have plaque at the gingival margin, redness, swelling, tenderness, bleeding on probing, and it's reversible if you take good care of your mouth. No bone loss, no attachment loss. Bone is still 1 to 2 millimeters of the apical of the CUJ. Okay, now you can have biofilm-induced gingivitis on a reduced but stable periodontium. This would be a perio maintenance patient that now has gingivitis. Pre-existing bone loss, because remember they're a perio maintenance patient, so they've had a bone loss, but they don't have any new bone loss, they just have inflammation and biofilm at the gingival margin. So that's biofilm-induced gingivitis on a reduced, stable periodontium. Alright, biofilm-induced gingival diseases. You can have a pregnancy-associated granuloma, which is a mushroom-like growth common in the maxilla and proximal teeth. Not cancerous, not painful. It's just an exaggerated response to biofilm. This is also known as a pyogenic granuloma, isn't it? Yeah. So there it is, pregnancy-associated granuloma. Plaque-induced gingival diseases. So So, let's see here. For people who are taking medication that affect the way we accumulate biofilm in our gingiva, it can happen from individuals taking phenytoin, I don't know how to say that, cyclosporin, and calcium channel blockers. Those all cause gingival enlargement. Onset is usually 3 months of taking medication. Basically, your gingiva has an exaggerated response to plaque. It's higher seen in children, and it's usually gingiva on the anterior sextants that are most commonly affected. So there is cyclosporin induced, phenytoin induced, and now you have non-plaque induced gingival lesions. So remember, you can have plaque induced issues in the gingiva and non-plaque induced. So non-plaque induced is hereditary gingival fibromatosis. This is when you have genetically enlarged gingiva due to fibroplasia. So medication isn't causing this inflammation. Biofilm isn't causing this, it's genetics. Okay? Papillon-Lefebvre syndrome. This is an autoimmune disorder where there's altered T and B cell function, and it's basically a rapid progression of perio in baby teeth and then permanent teeth. It also can cause an increased keratinization on the hands, palms, and soles of the feet. You have, never mind. And then the Chidak-Higashi syndrome, which we learned in Path. This is an autoimmune disorder as well, and you have a decreased phagocytosis, which can lead to premature exfoliation of baby teeth. Alright, so now you have gingival infections. Linear gingival erythema. Now remember, this is a gingival disease that is associated with not biofilm, but a infection. So this is associated with HIV. It's a redness of the free and attached gingiva. It's that red band of line that goes up and down the marginal gingiva, linear gingival erythema, and it doesn't respond to therapy. Alright, now you have non-biofilm induced gingival lesions, continued, which is what we've been talking about. You can have a specific bacteria that causes lesions in the gingiva. Gonorrhea, Treptonemia pallidum, Streptococcus species also. So this is herpetic lesions in the mouth. Painful in youth, and in adults it can cause hospitalization. And this is primary herpetic gingivostomatitis. It's where there's fiery red marginal gingiva, swollen papillae that bleeds easily, yellowish ulcers, and then dehydration is a concern. It's an initial oral infection with the herpes simplex virus. It has painful ulcers that rupture. Fever is present and it is painful. And it's very contagious. That's why most children get it. Alright, and then you can have Candida, which is a gingival disease from fungus, and linear gingival erythema, which is from fungus, and histoplasmosis, which is from Caver's lung or Spelunker's disease, which is a fungus. Alright. Now, and then you can have inflammatory and immune conditions that cause gingival issues. So, lichen planus, it's associated with women who have other autoimmune issues. It's kind of that, lichen planus is like white lines a little bit, and it's benign. Pemphigus, erythema multiforme, which is what Maven had. Alright, now periodontitis. So you can have different types of periodontitis. You could have necrotizing periodontitis, which is the necrotizing gingivitis, necrotizing periodontitis, and necrotizing stomatitis. You can have manifestations of systemic disease, such as a review of internal classification, and then periodontitis, which is your 1, 2, 3, 4 stages of perio, and then your extents, and then your grades. So, necrotizing periodontal diseases. You can have NUG, necrotizing ulcerative gingivitis, seen in college kids and people who are under a lot of stress. Necrotizing ulcerative periodontitis, NUP, which is the same thing but in the periodontitis patient. And necrotizing ulcerative stomatitis. Necrotizing periodontal diseases uniquely involve tissue necrosis. If disease is limited to gingival tissues, it's called NUG. The bacteria associated with this would be Fusobacterium and Provotella. And then if the disease includes gingival tissues and loss of bone and attachment, it's called NUP. So NUG is gingivitis, NUP is periodontitis. In NUP, you'll see Fusobacterium, Provotella, and also P. gingivalis. So in NUG, or necrotizing ulcerative gingivitis, there's tissue death due to limited gingival tissues, painful infection, primarily in the interdental and marginal gingiva, and it's loss of interdental papillae, bleeding, and pain. And then NUP is again necrotizing ulcerative periodontitis. It's also painful, but it's death of tissues combined with loss of attachment and bone. Extremely rapid, and it can produce loss of attachment within days. That's crazy. How do you know if you have NUG or NUP? You can have gingival necrosis, fiery red gingiva, spontaneous bleeding, intense oral pain, and a bad odor. Material alba plaque, soft tissue, stagnant saliva. Alright, and then you have periodontitis as a manifestation of systemic disease. Based on primary systemic disease, so that would be manifestation diseases such as leukemia or neutropenia. You can also have genetic disorders such as Down syndrome and leukocyte adhesion deficiency. And then you have abscesses of the periodontium. You can have a periodontal abscess, which is just an abscess that is a pus accumulating abscess that is a circumscribed area of tissue. Or you can have exudate, which is separation, which is an accumulation of pus. There's an example of an abscess right there. You can have pericornitis, which is the inflammation of the distal of the second molar after third molar extractions, where there's a flap of tissue that bacteria gets stuck under and causes a disease. You can have endodontic abscess, which is an abscess in the roots of the tooth. Pulp tissue is dead and results in bone loss around the apex of the tooth. Mucogingival defects, such as recession due to malocclusion. And then staging and grading. And I think that is it for pathogenesis and disease classifications.